Hi, everyone, and welcome to Hopkins at Home. I'm Michelle Johansson. I'm an assistant professor of neurology at Johns Hopkins University School of Medicine, and I have the privilege of taking care of patients with cerebrovascular disease. Today, I'm going to talk to you a little bit about stroke, what stroke is, and then tease you about some research that's up and coming, specifically with regards to the heart-brain connection. At the end, I'll be happy to address all of your questions. So just pretend that you have an opportunity to learn a little bit about stroke and then an opportunity to ask the physician all of the questions that you wanted to ask them, but maybe were either too fearful to do so or just never had an opportunity. So let's get started. I want to begin by bringing your attention to the fact that May is actually American Stroke Awareness Month. It has been such a tough year with COVID-19 and the pandemic, and many people have forgotten that it is important to take care of your health, not only from the perspective of COVID-19, but also with the perspective of other chronic medical conditions such as stroke and heart disease. So today I'm going to talk to you a little bit about stroke, what the definitions are, action that's necessary to take against stroke, treatments of stroke, the risk factors for stroke, and then finally, a little bit about that heart-brain connection. So first, the definitions of stroke. So how important is stroke? Well, stroke is actually the second leading cause of death worldwide. In the United States, we've been fortunate to see a decrease in incidence in stroke over the recent years, making it the fifth leading cause of death in the United States. But importantly, stroke is usually due to modifiable risk factors. That means that there is something that you or your loved one can do to prevent having a stroke. It is also interesting to note that while the overall incidence of stroke is decreasing in the United States, it's actually increasing in our younger adults, which is something that we need to be very aware of as we think about things like obesity and food choices, fears of diabetes in even younger kids, especially type 2 diabetes, and how it is that we can encourage physical activity among our youth. It's also important to know that stroke is only the beginning. So sometimes when we think about stroke, we think about what happens initially after you have a stroke. But there are cardiac events that can happen after a stroke. You can have disability and long-term handicap after having a stroke. Stroke is known to be associated with an overall poor quality of life. People can experience depression after a stroke, loss of income. If you're a truck driver, for example, and your vision is affected, how are you going to be able to provide for your family? Stroke is also associated with cognitive decline and dementia. So what is a stroke? You know, when we survey people, it's if you walked up to someone on the street and asked them what a heart attack was, for example, they might be able to explain that to you. But a stroke, sometimes people struggle with. Stroke specifically is blood traveling to the brain. And as a result of blood traveling to the brain, there's a flow that's associated with that. And this flow and the nutrients in the blood supplies oxygen to the brain. And the brain does not do well if it suffers ischemia or a period of no oxygen. So stroke occurs when an artery leading to the brain or within the brain is blocked or damaged. A clot can block an artery, or an artery can burst, reducing or blocking blood flow to an area of the brain. And these pictures are some examples of that. So here on the right-hand side of your screen, I show what's commonly referred to as the circle of Willis, which is this amazing structure that we have in our brain that enables blood to be diverted this way or that way if there's a blockage in one blood vessel. The brain does whatever it can to protect the integrity of the structures that you have in your brain. But if there's no way around it and you have interruption of a blood supply in one particular artery of the brain, then the brain will suffer damage. And that damage is specific to the functions of that part of the brain. So here I'm illustrating a region of decreased blood flow, and that region is called ischemia. Ischemia, if not reversed, is called stroke. Imaging helps us aid our diagnosis of stroke. And so if you've ever had a stroke or know people who have had a stroke, sometimes they're sent in for CAT scans or CT images or MRI images, for example. This is an example of some of the pictures of patients who have had strokes. You'll see here, this is something called a diffusion weighted image. This is where we look at acute stroke. For example, here I'm showing you a brain, two halves of the brain, and you can see this area here demarcated in white, and that's indicative of acute ischemia or an acute stroke. This person has had an embolic event with multiple small little punctate areas of stroke scattered throughout the brain. This is something that looks at blood flow. We'll talk about this a little bit more later in the talk. And then this is an image called a fluid attenuated inversion recovery image, or a FLAIR sequence, also using MRI, that shows me how old a stroke is. So after a certain number of hours, you can see ischemia on an MRI in a FLAIR sequence that you would not see on DWI. So this helps us not only figure out what kind of stroke a patient has had, but also lets us know how long ago the stroke happened. So if you or your loved ones were to have an image, the doctor could be able to talk to you about when your stroke might have occurred. This is a little bit more about blood flow. For those of you who are reading in the literature or interested in this, as there's been a lot of publications about this in the news. In 2015, there were a lot of stroke trials that came out that enabled us to do incredible things like thrombectomy, where you can go up into someone's brain using a catheter through an artery and pull out the clot. And we're able to do that now as a result of perfusion imaging. If patients have certain mismatches in cerebral blood flow, cerebral blood volume, mean transit time, how quickly blood is flowing to the brain or across the brain, for example, all of this gives us information about the timing of stroke, how big the stroke is, whether or not there's a reversible deficit, and we use this to help treat patients. So what is a TIA? TIA is a term that gets bantered about quite a bit and sometimes can be the bane of a cerebrovascular neurologist's existence because unfortunately it can be used too frequently or too often. A TIA properly is understood as a transient ischemic attack or a transient episode of neurological dysfunction caused by a focal brain, spinal cord, or retinal ischemia even, you can have a stroke in your eye, without acute infarction. So the deficits are reversible. And normally it resolves. The classic definition is less than 24 hours, with a typical TIA lasting about 5 to 15 minutes. So ischemic stroke, what is the definition of an ischemic stroke? Ischemic stroke happens when you have occlusion of a blood vessel by different things. For example, thrombus, that can happen in atherosclerotic disease, for example. Emboli just means that a clot broke loose and went to the brain. It can happen from the heart, the aortic arch, proximal vessels, or hypoperfusion even. If there's a period in which blood is not getting to the brain, for example, from a prolonged operation and maybe the blood pressure dropped as a result of some catastrophic event, that can also result in stroke. So here I'm showing you sort of the caliber of a normal artery. This is an artery that has that nasty atherosclerotic plaque. And then this is an embolus that's blocking blood flow. Emboli like to lodge at branch vessels, for example. And this is just different ways by which you can occlude a blood vessel, thereby leading to stroke. So what is a hemorrhagic stroke? A hemorrhagic stroke is slightly different. It's where there's blood in the brain. And one way that that can happen is through rupture of an aneurysm. This is classically called subarachnoid hemorrhage, a little bit different than an intracranial hemorrhage, for example, but blood ends up in the brain from rupture of an aneurysm for sure. You can also get rupture of a small vessel of the brain. You can get bleeding of the brain into the site of an ischemic stroke. So for example, if there's a clot that goes to the brain can also bleed as a result of having that clot lodged there, and the brain doesn't like that, so it can bleed around that stroke site. This is just a wonderful picture, and they have great information on the American Stroke Association website if you'd like to learn more. That's showing how aneurysms rupture and can lead to subarachnoid hemorrhage. Here I'm showing the internal carotid artery and just different blood vessels that feed the brain. These perforating small arteries can also bleed. So now that we understand a little bit about stroke, how do we take action against stroke? Well, there's three main goals that I'd like you to remember when you approach a patient for stroke. So the first one is the patient having a stroke. And if you have any thought at all that you or someone you love might be having a stroke, it really is an emergency and you need to respond right away, because there are things that we can do within a certain period of time that we can't do if too much time goes by without patients coming to the hospital. So for example, during the COVID-19 pandemic, when this is being recorded, many people unfortunately have stayed at home, even though they've been having stroke symptoms, because they've been afraid to come to a hospital. We would encourage you not to do that, because there are things, again, that we can do for acute therapy that we can't do if a certain amount of time goes by. The second thing is preventing a recurrent stroke. If you've already had a stroke, there's treatment that we can give you to prevent another one. And this is part of our diagnostic evaluation. We want to figure out the cause of the stroke. That's important. And then third, we also want to prevent early and late complications of strokes. I sort of alluded to some of those earlier. People who have strokes can have cardiac problems, right? People who have strokes can become disabled, and as a result of that may need special care at home. Our physical therapist, our occupational therapist, our speech therapist, all of those people are important in helping take care of patients after the fact. So what are the signs and symptoms of stroke? Well, it depends on the location of the clot and which part of the brain is in danger. In general, it's good to remember that the left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body. Now, that's not always the case. There are exceptions to that rule, but it's just a good general rule of thumb to think if someone has a stroke on the left side of the brain, in general, you're going to see manifestations on the right side of the body. So stroke signs and symptoms, these are really important to remember. And if there's one thing that you take away from this talk, I hope it's that you remember what the stroke signs and symptoms are. Stroke is sudden in onset. It happens all of a sudden. You're washing dishes, you're sitting watching TV, you're talking to a loved one, it happens. It's sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. You can have trouble seeing. That can actually be symptoms of a stroke in one or both eyes. You can get confusion or trouble speaking or being understood. You can have trouble walking or dizziness or loss of balance or coordination. You can have a severe headache with no known cause. And these are all important signs and symptoms of stroke. So when you think about the signs and symptoms of stroke, one of the ways that's easy to remember this is something called the B-FAST algorithm. B-FAST is just emphasis on the time, right? You want to make sure that you treat and get treatment for these symptoms quickly. So B stands for balance. You can have sudden loss of balance as a result of a stroke. The I, or the loss of vision in one or both eyes. We've talked about that before. Face having issues, for example, even your arm or your leg is weak and hanging down. Your speech is slurred. You have trouble speaking or seem confused. The medical word for that is aphasia. And then remember that time component is important. You want to call 911 right away. So that's just an easy way to try to remember signs and symptoms of stroke. Okay, so we talked about what a stroke is. We've talked about sort of the importance of recognizing signs and symptoms of stroke. So let's talk a little bit about the treatment of stroke. So stroke treatment, there's primary prevention and there's secondary prevention. So primary prevention is to keep a stroke from happening. Secondary prevention is to keep another stroke. Therapy, and there's chronic therapy. So acute therapy is sort of, we have that time limit again. Remember, I was talking about how important it is to get to the hospital so we can treat your acute stroke. Chronic therapy is that risk factor modification and control, and that's more focused on preventing another stroke from happening. Okay, so how do we treat stroke? Well, one of the exciting things that we can do is administer something called IV alteplase. So IV alteplase really sort of came on the scene in 1995, and since then there have been a ton of evidence that's come out supporting the administration of IV alteplase. There are new drugs that are coming out. For example, tenecteplase is one that is emerging rapidly on the scene. But the standard care, the one that's usually given, is IV alteplase, or IV TPA as it may be called. Basically, it's given through an IV line, which is why it's important to get to an emergency room or a hospital who can treat you with this medicine. And what it does is it quickly dissolves the clot and improves blood flow to that part of the brain. And so a significant number of people who would be eligible for IV alteplase don't get it because they don't get to the hospital quick enough. So that's why that emphasis on the time is so important. Usually we say that the window in which to administer is up to 4.5 hours. This is some educational information. If you'd like to read more, that's available once again on the American Stroke Association website. It's neat to see, though, as more and more evidence comes out, that we're able to push that window out even further, which is pretty exciting, based on some new advances that we've made in that imaging technology that I described to you before. But for now, you can kind of think of it as being given within 4.5 hours of stroke onset. So once again, why it's not a good idea to stay at home and wait until the next morning, because we would not be able to give you this medication. So I love this. This is from permission with Chick-fil-A and Dr. Victor Rutia, who also works here at Johns Hopkins. These are the cows from Chick-fil-A just telling us that we should give more TPA in addition to eating more chicken, according to them. Okay, so we talked a little bit about IV TPA, which is one thing that we can do, but there's also something else that we can do, and that's an endovascular procedure. So I alluded to you about this a little bit earlier when I talked about how we could take a catheter, go up into the brain and pull out the clot. And that's what's being demonstrated here. So we have lots of different devices that we can use. Majority of them are called stent retrievers. And essentially what happens is in an emergent setting where there are patients who specifically qualify using imaging criteria that shows that there's a perfusion-diffusion mismatch, which is basically a fancy way to describe that the actual core of the stroke is small and there's a big penumbra around that area of salvageable brain tissue. We can take these devices and go in through the arteries, usually through the groin, thread the catheter up into the brain, find where the clot is located, deploy the device, and pull that clot all the way out. Obviously, there are risks to this procedure, so it really needs to happen at what we call a comprehensive stroke center, which Johns Hopkins is, where there are people who are trained in this procedure and do it quite frequently. And then as stroke neurologist, our job is to decide who is eligible for this procedure, because we only want there to be good outcome and no harm. What's exciting about this is that since 2015, when this was sort of first coming on the scene, we've had even more and more evidence about this now, and we're doing this procedure even up to 24 hours after stroke symptom onset, which is amazing. We're really revolutionizing the way that we're taking care of our stroke patients. So just something for you to know, that this procedure is out there, that it's available, and that there are specific criteria on who would benefit from this. But I've seen remarkable improvement as a result of this procedure. Okay, causes of stroke dictate the treatment of stroke. So we talked a little bit about IV TPA, we talked about thrombectomy. So now, you know, how is it that we figure out what it is that we do with stroke sort of after those initial first critical day or so? Well, there's stroke that's due to emboli that arise from the heart, or called a cardioembolic stroke. There's large vessel disease of the extracranial blood vessels, large vessel disease of the intracranial blood vessels. Small vessel disease can lead to stroke. Abnormalities of the blood, so if you have clotting problems, that can certainly lead to strokes. Venous infarcts, you can actually get clots in the veins of the brain. And then finally, there's this group called cryptogenic or embolic strokes of unknown source. And that's a tough group to try to diagnose. And we'll talk about that a little bit at the end. Ischemic stroke is sort of the preponderance of the kinds of strokes that patients have. And then hemorrhagic stroke is a little bit less frequent, but is certainly devastating. And that's what we talked about before, where you have blood in the brain. And that's what I'm showing you here on these images. And then ischemic stroke is thought of as the more of the clotting problems. Okay, so secondary prevention. So let's say that you've had a stroke, and we figured out that you've had a stroke, and we work on trying to figure out the cause of the stroke. Then how do we go about trying to prevent you from having a stroke again? Well, antiplatelet agents are indicated for most ischemic strokes. Now, there are certain conditions that are treated a little bit differently. So blood clotting disorders might be treated differently. Atrial fibrillation is certainly treated differently, and we're going to talk about that in a bit. Infection or inflammation of the blood vessels, if that's leading to clots and strokes, that will be treated differently. And then the choice of the antiplatelet agent, I get this question all the time from patients. It really depends. This is where the art of medicine comes in. It really depends on the allergies of the patient, the intolerance to different drugs, other comorbidities. If there's a benefit from giving you one medication because you have a need for it from a cardiac perspective, for example, and then cost of the medicines as well as compliance with therapy. So just as an example of some of the antiplatelet medications that we have, so aspirin is the one that's most commonly known, been around for centuries, right? But it's still incredibly effective at preventing platelets from sticking together and forming blood clots that then go to the brain. And hence, that's why we call it an antiplatelet medication. The dose can vary. We usually use 81 milligrams or 325 milligrams. It can certainly cause some GI upset, right? Aspirin is known to be associated with ulcers, for example. So if you have ulcer disease, that's something to talk to your neurologist about. And then here's some other examples. We have ticlopidine, which is Ticlid. We also have Plavix, which is clopidogrel. These medicines sometimes have two names, but it's the same drug. And then Agrinox is a combination of an aspirin and dipyridamole. And there's different side effects associated with these. And so sometimes that helps guide us as far as which medication we might choose. Okay, so antiplatelet medicines are different from anticoagulation medications. And this is another question that I also get, is when I ask whether or not patients are on a blood thinner, for example, they'll say yes, and they think that they are because aspirin in some ways thins the blood, but it's just a different mechanism. So anticoagulation is certainly used if you have atrial fibrillation and has had a stroke, if you have mechanical heart valves, if there are certain problems that make your blood clot abnormally, if there are clots in the veins of the brain. These are all examples of when we would use an anticoagulation medication. There are many of them, and there are even more in development. Warfarin or Coumadin is probably the one that's the most well known. And this is just listing what the target is for those of you who are interested in these sorts of things. It's a vitamin K antagonist. And so as a result of that, for example, your doctor may have told you to be careful and not eat truckloads of spinach because warfarin is acting to inhibit vitamin K. So all of these drugs have different targets. These are some of the newer agents that have come out: dabigatran, rivaroxaban, apixaban, edoxaban. These all also have brand names associated with them. So for example, apixaban is Eliquis, but it's the same medicine. And so what these drugs do is they work on these different items here that are listed that are a part of your clotting cascade. So there are different steps that your body goes through to form a clot. And so these medicines target different components of those steps. And as a result of that, it helps prevent you from forming clots. So possible reasons why you may be placed on an anticoagulation, I just throw these out there because the evidence for these is not as strong. But sometimes if you've had a recent heart attack, you may be placed on one. If you have problems with your heart pumping, or if your ejection fraction is really low, or you have heart failure, you may be placed on one. If you have a tear in a blood vessel wall, something called a dissection, you may be placed on anticoagulant. Okay, so what's the difference? They both prevent blood clots, but in different ways, right? So this is for all of our scientists in the audience, or for those who really enjoy learning about this. Basically, antiplatelet agents prevent formation of what's called a white thrombus. Platelets aggregate and they form in the setting of fast flow. So that's what an antiplatelet medicine does. While red thrombus is stasis of flow, so blood just sitting. And so to prevent formation of red thrombus, it's necessary to use an anticoagulant. Okay, so we talked about what stroke is, we talked about what you can do about it, we talked about how important it is to prevent one and some of the medicines that we can use. So now I want to talk a little bit about risk factors for stroke. Remember, I said that most stroke had modifiable risk factors associated with it. This is a whole 2-hour lecture in and of itself, but I just picked some of the hot topics that I get lots of questions on when my patients come to see me in clinic, for example. Okay, stroke can be prevented. Look at these numbers. So an analysis using data from the Global Burden of Disease study, about 90% of the stroke risk could be attributed to modifiable risk factors, right? High blood pressure, obesity, high glucose levels or blood sugar problems, hyperlipidemia or high cholesterol. And then 74% can be attributed to behavioral risk factors such as smoking, sedentary lifestyle, or an unhealthy diet. That's incredible. Can you imagine what would happen if we started making changes in some of these areas of our lives? Okay, so what are those risk factors? So this is a wonderful study that they did that was published in Lancet Neurology that sort of took a look at all of these different risk factors for stroke, and they ranked them in importance, and they also broke it down by country. How interesting. So for example, globally, if we think about the whole world, the top 5 risk factors for stroke are high systolic blood pressure, absolutely. Diets low in fruits, a high body mass index, diet high in sodium, and smoking. And then here's where the United States falls. So our number 1 risk factor is blood pressure. Number 2 is a high body mass index, okay? So these are things that are important to think about when you think about what it is that you can do to prevent a stroke from happening. Okay, so let's talk about high blood pressure. High blood pressure is really devastating. And the reason for this is there are many people walking around who have high blood pressure who do not realize it. And so therefore we refer to it as a silent killer. And the reason for that is because if you have high blood pressure, your heart works harder. It scars and damages arteries not only around the heart, but also those leading to the brain. It can lead to fatty buildup in those arteries. You can get brain white matter damage as a result of blood pressure. So blood pressure categories. So it used to be that sort of the standard number that was thrown out there was 140/90. And we've realized that that really should be stage 2 hypertension, that we need to start pushing patients lower than that. So systolic is the pressure in the arteries when the heart beats, and diastolic is the pressure in the arteries between heartbeats. Systolic is that top number of your blood pressure. Diastolic is the bottom number of your blood pressure. And so here's the categories: normal being less than 120 and less than 80, right? Unbelievable. And most people walking around don't have that kind of blood pressure. So it's really important that we think about this when you go to your primary care doctor, for example. They check your blood pressure, it's 170/100, and you say, oh, I'm a little bit anxious. That's fine, but could it be that you actually have underlying hypertension and you need to be monitoring that for a longer period of time, or even checking it at home to see if you need a medication? Obesity, obviously obesity is associated with higher rates of diabetes. Obesity is associated with blood pressure problems. Obesity is associated with stroke. And so here's something called the body mass index. If you've never heard of this before, body mass index is something that we use in the medical community to sort of track where your weight stands, right? So if you are a Ravens football player and you're built like a log, your body mass index is going to be higher than a smaller petite woman. But it may be that the smaller petite woman is more unhealthy than the Ravens player. And so one way to get around that is body mass index, because it adjusts not only counts for your weight, but it also adjusts for how tall you are. And so it's sort of a little bit better than just how much you weigh at getting at whether or not you're obese. And obese is defined as 30 or higher is considered to be obese. And in case you're all trying to calculate your BMI, I put how you would do that down here. Okay, you are what you eat. So there's an inverse relationship between fruit and vegetable intake and stroke. So think about this number. For every increase in serving a day of fruits and vegetables, the risk of stroke goes down 6%, right? Especially those green, yellow vegetables. There's been data that shows about 32% reduction in mortality from stroke. That's unbelievable. So I also get this question all the time, which is, okay, doctor, I know I'm supposed to lose weight. What diet would you recommend? And the easy answer, but also the best answer for that, is the diet that is the lifestyle change that you're going to stick with that doesn't harm your health. That's the best diet for you. So the one that I tend to recommend, just because it's more of a lifestyle change and it's also easier to stick with it, and it has data behind it, is the Mediterranean diet. And you can think about it in terms of what is it that they eat over in the Mediterranean, and how can I sort of adjust what it is that I'm doing to what it is that they're doing. So olive oil, right, is very healthy. It's much healthier than butter or lard or fat that we might use to cook our foods in. It really emphasizes vegetables and fruits as well as fish, and which we know to be healthy for the brain. It reduces red meat consumption. It encourages you to cook with natural seasonings and natural flavorings and not artificial processed food. And then while it says maybe a little bit of wine is okay, it limits that amount. Another diet is the DASH diet. There was a lot of work that was done actually here at Johns Hopkins about the DASH diet. The DASH diet is dietary approaches to stop hypertension. And so it focuses on things like eating vegetables and fruits and whole grains. And one of the things that it does is it really limits the amount of salt that you have in your diet. It also limits sugar. And it was shown to actually decrease systolic blood pressure by 8 to 14 millimeters of mercury. So that's quite impressive, right? If we're thinking about how important blood pressure is, if there's things that you can also do in your diet that would help lower your blood pressure, that's really important. Now, I want to say if you have high blood pressure, dietary changes alone are probably not going to be sufficient for you to treat your blood pressure. You'll probably need a medication, but how excellent to know that there are things that we can be doing from a dietary standpoint to help stop hypertension. Smoking, clearly smoking, I think there's more understanding in the lay community about how dangerous smoking is. Nicotine, we know, can increase heart rate and blood pressure. The carbon monoxide and tobacco depletes oxygen from the brain. It damages blood vessels. It lowers your ability to fight infections. It decreases your good cholesterol. And there's even a further increased risk with oral contraceptive pills. So if you're a woman and you're on oral contraceptive pills and you're smoking, your risk of clotting is even higher. There's also a lot of controversy now about vaping. There's a lot of great work that's being done at Johns Hopkins that shows that vaping is harmful. So if you are smoking and you think that vaping is the answer, I would strongly discourage you from that. And we have tobacco clinics, et cetera, that can help sort of walk you through great ways to just get off of smoking, get off of vaping for the long term to decrease your risk of clotting. So this is just sort of a high overview of some of these risk factors for stroke. And there's a lot of information on the slide, but I just show it to you to say that all of these risk factors work together, right? So it's not just one here and one here, they work together. So as we get older, right, we know that age is also a risk factor for stroke, but obviously you can't control how old you are. But you can do things about your diet. You can do things about your blood pressure. You can do something about whether or not you're smoking. And depending on how old you are and what your sex is and what your blood pressure is and what your cholesterol is and what your medical history is, all of these things overlap and contribute together to increase your risk for stroke. So what can I do? What can I do about it? Well, it's really important to know that stroke is a life-threatening emergency and that most stroke is attributable to modifiable risk factors. Ischemic strokes and hemorrhagic strokes vary by mechanism, and treatment should be specific to the type of the stroke that you've had. And you want to advocate for yourself and your loved ones and ask questions. If there's something that concerns you, bring it up to your primary care doctor. If you see someone who's continuing to smoke and you love them tremendously, say, you know, there are resources out there. There's 1-800-QUIT numbers. There are nicotine patches. How can I help you get off of this so that way you yourself will feel better and can live longer stroke-free? Okay, so that was a lot of information about stroke. And so in the last 10 minutes or so, I just want to talk to you a little bit about this heart-brain connection. It's my passion, it's my research interest. I do a lot looking at the way that the heart informs what we know about the brain. The brain is one of the most interesting organs in the body, I will say very biasedly, but we're learning a lot more about how these things are connected and how they sort of inform the way that we take care of our stroke patients and even just the general population. So cardioembolic stroke is that stroke that, one of the stroke subtypes that I mentioned to you earlier on in the lecture. And cardioembolic stroke is an important area for me personally. My father actually had a cardioembolic stroke, and I take care of lots of patients who have cardioembolic strokes. It's a devastating stroke type. It's a complex disease, right? Because all that's telling you is that a clot has come from the heart and gone to the brain. But clearly there are multiple reasons why clots can come from the heart and go to the brain. There's an anticipated increase in incidence. So remember that I said at the beginning that we anticipate that there's going to be an overall decline in stroke in the United States, which is excellent news, although it is increasing in our younger adults. But cardioembolic stroke, we don't anticipate that to be the case. Among stroke subtypes, we actually anticipate there's going to be an increase in incidence. And importantly, cardioembolic stroke and stroke in general has been associated with dementia. And dementia, we know, is devastating for so many different reasons. And currently, we do not have a cure for dementia, although there's lots of great research going on. So if there are things that we can do from a heart perspective or a stroke perspective to prevent dementia, that seems to be sort of the best path to take, at least at this time. So the most common cause of clots coming from the heart is atrial fibrillation, and I alluded to that a little bit earlier. So in the heart, you have 4 chambers in the heart. You have 2 atrium and you have 2 ventricles. And the left atrium is sort of thought of as the pacemaker of the heart. You have something called the SA node, and it kind of sets the pace for how your heart beats. And so a normal heartbeat beats along, and atrial fibrillation is where you get irregular electrical signals that disrupt the normal conduction between the SA and the AV node, and it causes the atria to quiver. And so as a result of that, if you think about it, if the atria is quivering, that means it's not actually pumping and forcing the blood out. So you get that stasis of blood flow that I talked about before that can lead to clot formation that can break loose and go to the brain. Here's some great information. If you want to read more about this, I encourage you to go to the American Stroke Association website. This talks a little bit more about what atrial fibrillation is. It's important to know that if you have atrial fibrillation, you probably don't realize that you have atrial fibrillation. If you do have atrial fibrillation and you are symptomatic, sometimes it's felt to be a racing or a pounding or a fluttering sensation in your chest. You could feel off, you could feel short of breath when going upstairs. But that fatigue, shortness of breath, lightheadedness, racing heart doesn't always present. And so it's important to know that you could have no noticeable symptoms whatsoever. So if you go to your primary care doctor and they do physicals, one of the things that they'll probably do is something called an EKG. And in EKG, you can pick up atrial fibrillation, atrial flutter, for example. Here's a multifocal atrial tachycardia. So there's different sort of types of atrial tachyarrhythmias that can happen. But what's important to know about atrial fibrillation, once again, for this talk, is that people who have atrial fibrillation are at greatest risk for stroke, 5 times higher stroke risk than the normal population. You know, it's also important to know that, you know, you need to ask, right? So maybe you have a strong family history, and maybe that you want to get monitored for a period of time to know if you have atrial fibrillation, and your primary care doctor should help you work through that. If you have had a stroke and you have atrial fibrillation, then you absolutely need to be on anticoagulation. That's what we had talked about earlier, right? With the rivaroxaban and the apixaban, those kinds of medicines, because those medicines are the most effective therapy that we have right now at preventing you from having another stroke. So it's really important to talk to a doctor about getting you on a proper medicine, especially if you've already had a stroke, to prevent a stroke from happening again. Here's an example of some of those implantable loop recorders I was mentioning about, how you can have an EKG to look for atrial fibrillation, but you can also have these implantable devices inserted right underneath the skin. This is an example of a coin. You can see how teeny tiny these are. So if your doctor has ever talked to you about an implantable loop recorder or an implantable cardiac monitor, or something that goes just underneath the skin to monitor your heart for atrial fibrillation, these are some of the devices that they may be referring to. Okay. Here's sort of a breakdown of ischemic stroke, and one of the areas that I do some research on is this group that's the cryptogenic group, or the people who have strokes and we can't figure out the cause of their stroke. And you know, look, an estimate, at least within this paper, it can be even up to 1/4 of our patients with ischemic stroke were unable to find the cause of their stroke, and clearly that's frustrating for patients, right? So here is just an example of, you can imagine maybe this is the stroke patient, and this is either her daughter or a loved one who cares a lot about her, and the fact that she's had a stroke, and right now it's being labeled as cryptogenic, in which they don't know the cause of the stroke. And they can be very frustrating, it can be very overwhelming, and so that's why I do a lot of research in this area. There's a podcast where I talk about sort of this embolic stroke of unknown source, which I'm not going to go into today. But for those of you who are interested, you can scan this code and it will take you to the American Neurologic Association website, where we have lots of great podcasts on there sort of talking about some of these things. Here's an example of an echocardiogram, which is one thing that I use to look at the hearts of patients in which I do research in. And it enables me to look at the way that the heart is beating in real time. And then some of the stuff that we're doing is looking at how the heart beats in the brains of patients and seeing if we can help sort of come up with where it is that these clots are coming from in our stroke patients, not only in cardioembolic stroke, but also for those patients in which we have no diagnosis of their stroke subtype. So just to say that there's ongoing research here at Johns Hopkins looking at cardiac structure and function and how that helps us diagnose the cause of the stroke and how this could change the way that we currently treat these patients. So, I hope in years to come that I'll be able to come back to you and have some very exciting results from what it is that we're doing. And here's some examples of papers that have been recently published with regards to this effort. So also to know that the heart appears to impact cognition. So potential reasons why the heart can impact cognition is from stroke, right? Clinical strokes certainly impact cognition. And we know that if you have a clinical stroke, you're at higher risk of cognitive decline and dementia, which is one reason why it's so important to prevent strokes, right? So that way we don't have to worry about those ramifications later. You can get hypoperfusion to the brain maybe, or even subclinical infarction from heart disease that we don't realize. So there's ongoing brain insult that we don't realize. White matter changes have been noticed in brains of patients who have some cardiac changes in their heart. And so we've been doing some research in this area as well, talking about the role of cardiovascular disease and the way that not only our patients have strokes, but also in the way that they're thinking or cognitive impairment. Okay, so with that, I would like to conclude. I thank you guys so much for being a part of this Hopkins at Home talk. And I'm really excited to hear some of the questions that you have to ask. I wish we could be doing this in person, but I'm grateful that it is a stroke month and we can highlight stroke and the importance of stroke and how we care for patients with stroke. So I'll start paying attention to the chat now and hope to answer any questions that you may have. So thank you so much. The first one that I see is, can you share the respective risk and benefit ratio in stroke prevention between warfarin versus direct anticoagulants versus just baby aspirin? I think that's an excellent question. So it really comes down to the type of the stroke that you have had. So for example, we know that treating patients, every single patient with an anticoagulant, be it warfarin or direct anticoagulants, for example, or DOACs, as this person is referring to, is not helpful. There has been data that has come out to show that treating all patients with blood thinners, specifically like a DOAC or warfarin, can be harmful and just increase risk of bleeding. So right now, the data that we have supports using these anticoagulants in patients who have atrial fibrillation, for example. So there are very specific indications for them. If you don't have a specific indication for it, then aspirin is the best way to go because it prevents those side effects of having massive GI bleeding or bleeding into the brain, for example. If you do have something like atrial fibrillation, then absolutely the benefit lies with either a warfarin or those DOAC medicines that I mentioned before, the direct oral anticoagulant medicines. And because of that, because of the type of clot that you've had, the risk of bleeding, for example, in the GI tract, your gut, or in the brain, is completely outweighed by the benefit that you receive from being on those medications. So that's sort of the answer to the first question. It kind of depends on what type of stroke that you have had. Then the second one is, what kind of exercise do you recommend to reduce risk of stroke specific to the heart-brain connection? All right, that's great. So all exercise is good exercise. The best exercise is the exercise that you enjoy, right? Because it's the exercise that you'll do every day. So the American Heart Association, American Stroke Association recommends that you do about 30 minutes of a moderate cardiovascular exercise 5 times a week. If you do more vigorous cardiovascular exercise, then you can do it a little bit less frequently. But the point of exercise really is just to know that not only is it good for your cardiovascular system, but it is good for your brain. It's been shown that people who exercise have increased longevity, right? They live longer. They have increased cognitive reserve. So the way that they think and go about their daily activities is improved. We know for sure that blood flow to the brain is better in people that exercise. They tend to have increased collaterals. So all of those are excellent things to do as far as exercise is concerned. If you have other medical conditions, then that also may help you sort of think about the way that you exercise, right? So if you're a woman and you have thinning of your bones, then you may want to do more weight-based exercise. If you are a person who needs to be careful with, for example, you've had trauma, then maybe some more of the stationary exercises that you can do, like a recumbent bike, might be necessary because you may not be able to move as much as you would be able, as someone else might be able to. But still, regardless of who you are, there's some degree of exercise that you can do. And it is important to the heart-brain connection. So thank you for that question. The next one is, do changes in heart rate related to stress or anxiety increase risk of stroke? That's an excellent question as well. So people will tell me, does stress cause stroke? So the simple answer is no, stress does not cause stroke. However, stress is certainly linked to what's called a sympathetic response. So in a sympathetic response, you increase your heart rate, right? Sort of that fight or flight response. And people we know who are undergoing a lot of stress, a lot of fear in their life, for example, if they feel like they're in an unsafe environment, then that certainly can lead to early changes in the heart and lead to early signs of atherosclerotic disease. So while stress itself doesn't lead to stroke, we know that living in chronic states of stress, for example, is not healthy. So we all have stress, right? So we have to come up with ways to try to deal with it, be it exercise, for example, or social support systems, being a part of your church, etc. Those things are important to help release stress. So that way your body is not years down the road showing signs of chronic stress problems. The next question I have is, have there been any indications of increased incidence of stroke related to COVID-19? Excellent question. Perhaps due to an increase in stress or anxiety, sure. So COVID-19 has been stressful for everyone, right? It's been stressful for the people in the hospital. It's been stressful for the people outside of the hospital. That is an excellent question about COVID-19. So I'll tell you a little bit about the work that's been done at Hopkins and then sort of the work that's been done globally. So I think the short answer is we don't really know. We're going to know a lot more after the COVID pandemic, and we can look at all the patients who have had strokes. Right now, the best evidence that we have is from case reports or small center studies done at one hospital, for example. We certainly did see a lot of clotting related to patients who have COVID-19. We had to adjust the protocols that we were using in patients to thin their blood, for example, to try to prevent clots in patients who had COVID-19. We also saw people with COVID-19 who had strokes. That being said, it also appears that normally what would happen with COVID-19 is that there are patients who had vascular risk factors, right? For example, diabetes or heart disease or atrial fibrillation, or already had some of that plaque buildup in the artery of their brains. And COVID-19 was kind of what pushed them over the edge to present with a stroke. So at least in the Hopkins experience and in our own data analysis, what we have found is that the majority of patients already had risk factors for stroke, but COVID-19 sort of pushed them over the edge to manifest as stroke patients. So yes, I have taken care of patients who had both COVID-19 and stroke. Do I have any information related to incidence and increase of stroke in younger adults? Sure, absolutely. So there is a talk that I recently gave for Women's Journey, actually at Johns Hopkins, talking about the increase in incidence in younger people with stroke. So there certainly is data out there. What we're seeing is more of these modifiable risk factors manifesting themselves in younger adults, right? So we never, ever, ever used to see type 2 diabetes in a 16-year-old, right? Or in a 12-year-old or in a 10-year-old. Kids were always thought of as having juvenile diabetes, and now we're starting to see type 2 diabetes in our kids. Recess is being taken away at school. Obviously, COVID-19 led to lots of sitting and being on a computer. So there are certainly things that are starting to manifest in kids, and then those kids become young adults. And so that's why we're seeing differences in our youth, we believe. There's some other exciting research that I'm doing looking at hearts, for example, in younger patients, but a lot of it is due to modifiable risk factors. Okay, next questions I have. What measures can be taken to prevent hemorrhagic stroke? I know we're running out of time here, so I'll try to take these quickly. Hemorrhagic stroke, the biggest one is blood pressure. So if you had to pick one, it's lower your blood pressure, and that will prevent hemorrhagic stroke. Are there any known disparities in the availability of stroke treatments? That's a great question. You know, I think that as we think about health more and more, we're more in tune with things like disparities. I think that we are doing a better job of, for example, targeting blood pressure clinics in areas of low income and low socioeconomic status where they may not have access to primary care doctors. So I do think that there are absolutely disparities in availability of stroke treatments. And I know that there's ongoing work, especially, for example, here at Hopkins and with the Bloomberg School of Public Health, to really do a better job of addressing some of these disparities. Let's see, are there certain risk factors which make someone more susceptible to a certain type of a stroke? Absolutely, yes. So if you have family history of stroke, that can absolutely increase your risk of stroke. As we talked about before, if you have some of those other disease states, they can work together to increase your risk of stroke. So that's why having an individual approach to you as a patient is so important, to make sure that we address what it is that's presenting right there in front of us as physicians, because each patient is different. And so the way that we treat you is different. What is the difference between xarelto and the other antiplatelet medications that you mentioned? Okay, so xarelto is a blood thinner, not an antiplatelet medicine. So xarelto falls in that anticoagulant category, while the antiplatelet medicines are aspirin and Plavix and Ticlid. So they're actually quite distinct from each other. They're completely different, actually. Antiplatelet is that white clot that we talked about before, while xarelto is that red clot, for example. Let's see if I missed anything up above. I have another one. Is atrial septal aneurysm a cause of stroke? Oh, wow, what a great question. That is certainly within the cardiac realm of what I'm interested in. So atrial septal aneurysm can be associated with what's called a PFO, so a patent foramen ovale. So patent foramen ovale is something that we all have. We're all born with little holes in our heart, and then they sort of close over time as the child matures. So that's why children can have innocent heart murmurs, for example. As adults, sometimes patent foramen ovales don't close, and if they're associated with something called an atrial septal aneurysm, then that can increase your risk of stroke, because it's thought to be associated with clot moving from one side of the heart to the other side of the heart and then getting to your brain. So those are all excellent questions. Thank you guys so much. I know it's 1 o'clock. Apologies if we had a little bit of issue with the video there earlier, but hopefully you're able to learn a lot about stroke, what stroke means, how to prevent stroke, and you had some excellent, very well-informed questions. So thank you once again.